Welcome, and thank you for joining us for today's webinar on Medicaid in Motion, where we'll talk about the current political considerations and processes shaping the future of Medicaid, as well as how to navigate the known changes and opportunities and those that are still developing. My name is Andrea Maresca, and I'll be moderating our discussion today with several experts from Health Management Associates and Levitt Partners, an HMA company. Just some quick notes. We had tremendous interest in this webinar, and we will post the replay and the slide deck on the HMA website in the coming days. Now, I'd love to tell you that we intentionally scheduled this webinar for the day after the House vote on the resolution. Either way, we are fortunate that the timing worked out to provide us with a lot to discuss today. We're going to spend some time talking through where we are today with the budget resolution and the reconciliation process and what could come next. We'll discuss several aspects of Medicaid proposals that are under consideration in the context of these proposals. Then we'll turn our attention to the Trump administration and the policy priorities of new leaders, several of whom are still in the process of formally joining the administration. We'll touch on what issues and policies might carry over from the president's first term and potential new initiatives. Finally, we'll talk through the implications of these developments for Medicaid stakeholders, which information is actionable, and what needs to be done. As we go through our brief presentations, please feel free to put your questions in the Q&A box. We are planning to have plenty of time at the end to pose these questions to our experts. So with that, I'll get started by introducing you to our panel today. Beth Kidder brings over 25 years of experience in the Medicaid program, working both at the state and national levels. She's a former Medicaid director for the state of Florida. During that time, she also served as president of the National Association of Medicaid Directors, where she represented the interests of all state Medicaid directors on critical federal policy issues. Caprice Knapp is also a former Medicaid director coming from the state of South Dakota. She too brings significant experience on the national level, having been a former Congressional Budget Office health advisor and a fellow working on the Hill in the House of Representatives, as well as serving on the board of the National Association of Medicaid Directors. Josh Trent, highly respected for his experience in legislative and executive branches of government. He served as a health counsel on the Energy and Commerce Committee and a senior advisor for a member of the Senate, as well as in executive branch positions. Liz Rowe is one of our budget gurus with the Levitt Partners team. She served as chief counsel for the Senate Health Committee and as the health policy director for the Senate Budget Committee. Liz, I'm going to turn it to you to start us off today. Help us understand where we are in the budget process and, more importantly, what is going to happen next.
Great. Thanks, Andrea. And you're right. We probably couldn't have picked a better date to have this conversation. One of the things we're here to talk about Medicaid. And so you're probably thinking, why the heck are we talking about budget and what is reconciliation? Well, budget reconciliation is a process that is available to Congress to pass legislation with just a simple majority in the Senate. And so what does that mean? It means you can pass a bill with 50 votes rather than 60. So if, for example, right now you're the Republican Congress and you have a majority in the Senate, but maybe not a full 60 votes, reconciliation becomes a really, a possible tool to pass your legislation quickly. One thing that's going to be really important to kind of understand as we have this conversation is what is the budget and what is budget reconciliation? So the way I think about it is the budget sets your top line numbers for spending and how much taxes are going to come in. But it doesn't actually do anything. It doesn't become signed into law. It's really just a guide for Congress. Anything that's in the budget requires Congress to come behind and do its work. Well, over a long period of time in budgets where they proclaimed they were going to save a certain amount of money and then Congress kind of didn't follow up and do their job, the budget reconciliation process was created. And that's what is where we are in the beginning of the budget reconciliation process. So, for example, I'll try to make it a little bit louder on my end if you guys are having a hard time hearing. Sorry about that. So with the budget reconciliation process, what the budget reconciliation bill does is it tells different committees that they have to pass legislation in line with what's in their budget. So, for example, if the budget says you have to save $50, budget reconciliation is instructions to the finance committee telling them that they have to save $50 and giving them a deadline by which they have to do it. So this is the process that we're looking at, where Republicans want to use this for passing an extension of the Tax Cut and Jobs Act, maybe doing some defense spending, some border security spending, and that's really bringing into context these healthcare changes. Because we're talking about a budget resolution as the starting point, we actually have two bites at the apple this year because Congress didn't pass a budget resolution last year. So right now we're talking about a fiscal 2025 budget resolution, and potentially later in the year, we could be talking about a fiscal 2026 budget resolution. The other thing to keep in mind is that budget reconciliation bills need to be offset. So that means the more spending that's included in the bills, so for example, on tax credits or tax cuts or any of the other defense priorities, there needs to be offsets. And that's where Medicaid is coming into the conversation. Finally, as we've talked about, this is a process that is a little bit more intricate than the regular legislative process, and has a lot of bumps and turns in the process. And so it's really important for healthcare stakeholders to be able to understand what comes next. And so if we go to the next slide, we can see kind of where we are today. And we have two budget resolutions that Congress is looking at. On one hand, we have the Senate passed budget resolution. The strategy the Senate Republicans are taking is to basically do two bills this year, to use this budget reconciliation process twice. The first time would be on defense, border security, and energy. And the second would be later in this year, focusing on tax cuts and healthcare. The budget resolution in the Senate creates March 7th as the deadline by which committees would have to pass their legislation to be in compliance with these instructions. And again, interestingly, the Senate budget resolution creates very nominal directions for the committees in the Senate. Health and finance that have jurisdiction over most healthcare programs each have to reduce spending by no less than $1 billion. So this gives the committees a lot of flexibility in how they comply with these requirements. On the other hand, the House, which just passed their budget resolution last night, is going up for this approach where they want one big beautiful bill, which the president has endorsed, where they would do their defense, border, and energy spending at the same time as doing tax cuts and healthcare. They give the deadline for their committee action as March 27th. And so where we're really trying to focus in on impacts on Medicaid, one of the things that we look at with budget reconciliation is which are the committees that are given instructions and what are those instructions. And so, for example, the Committee of Energy and Commerce in the House, which has jurisdiction over Medicaid, is given an instruction to reduce spending by no less than $880 billion over 10 years as part of that reconciliation bill. And so that's where we're looking at, okay, well, then what's in Energy and Commerce's jurisdiction where they could make some of those savings reductions. And that's kind of what's coming to play with Medicaid. And so on the next slide, you can see, it was big news last night that the House was able to pass a budget. Again, this is the first step in the process. And as you can see on the screen, there were a number of members that had raised concerns prior to the vote. Last night, at one point, the House Republicans pulled back the bill and then decided to go forward. The only Republican that voted against the budget was Representative Thomas Massie from Kentucky. But as you'll see, the other two quotes from Representative Bacon and Representative Burchett talk about what I call as the Goldilocks problem. On one hand, you've got members saying, I want to see more saving reductions in the budget. I want to see exactly what policies they come from. I want to have certainty around what we're going to be doing, particularly in Medicaid. On the flip side, you may have some members that say, I think that we're cutting too much. I'm concerned about it. We need to actually lower the amount of spending and lower the amount of cuts. And so on one hand, again, Goldilocks, it's like, my porridge is too hot, my porridge is too cold. So if you go to the next slide, this is kind of where we're at. We have a Senate budget and a House budget. They've got some of these differences. And now the House and Senate Republicans have to get together and think about all of these different scenarios. do they do one bill? Do they do two bills? How do they manage this very narrow vote margin? What is the appetite for actual Medicaid reforms? And I think we saw in 2017, the last time there was a Republican Congress with a Republican president, they came in with very similar slim majority and spent a lot of time and a lot of political efforts to repeal and replace the Affordable Care Act and enact some significant Medicaid reforms. And there was a political price to pay. And also there were a number of policy and procedural hurdles. So there's a real question as to whether or not, members in the House and Senate have the appetite to go through that again. There's also the issue of, raising the debt ceiling. That's something that has to happen this spring. And so, how do you have a conversation about federal spending and raising the debt ceiling at a time when you also may be passing legislation that could also be having a negative impact on the debt? So next steps, as we said, is the House and Senate Republicans need to get together and decide on, a budget resolution that they can agree on. I think it's more likely that they'll do a process which we call ping ponging, where they'll kind of agree on, the Senate will agree on maybe a version of the House budget that they can live with, pass that, and then send that back to the House, versus a traditional conference process where, the two sides would get together and have a formal process to come up with a compromise bill that they would both pass. So again, once we have the budget resolution, then we'll move on to the authorizing committees where we'll get to see more about, which are some of the health policy options that are in play. So thanks, Andrea.
Great. Next, we'll actually one question, Liz. Going back to the 880 in the House resolution, do they have to does all of that have to come from Medicaid?
No. So actually, the budget resolution itself, when it gives these reconciliation instructions, if they mention specific policies, that has actually no impact on what the committees can actually do. So the committees could touch anything in their jurisdiction. The thing that's interesting to watch is in the Senate, for example, the Finance Committee has jurisdiction over Medicaid, but it also has jurisdiction over a number of the revenue provisions as well. So in the Senate, if they decided, if the Senate ended up getting a higher instruction for finance, and the Finance Committee decided that they couldn't, take all of this from Medicaid, they would have other options to pull from. And one thing I should have said is that when we're talking about budget reconciliation, you can't touch things like discretionary spending, so the spending that goes through the appropriations process. So we're really only limited to what we call mandatory spending. And the major programs there are, Medicaid, Medicare, the ACA tax credits, TANF, food stamps, and some other benefits. Social Security is not actually part of the budget, so it's exempt from reconciliation, but those are the types of policies that you could look at. There's been some instruction from the White House that the president does not want members touching Medicare benefits or Medicare in general. So that's part of why we're seeing this focus on Medicaid.
Great. And Liz, there was one more quick question about timelines or deadlines. Is there a deadline for completing work on the FY25 budget?
Yes, technically the FY25 budget needs to be completed by the end of this fiscal year. So they have until October to essentially pass an FY 2025 budget and the reconciliation legislation that would be part of that. And again, remember, they have another bite at the apple, so they can always do a second budget resolution this year.
Great, thanks. I know we're kind of building up questions in the queue, and we'll get to more of those later, but let's talk, Josh, about some of the specific proposals, specific Medicaid proposals that are being discussed as part of this process.
Thanks, Andrea. This is where the rubber really meets the road. To Liz's point about the Goldilocks problem, this is where the budget hawks want to see specific policies that make real reforms, and more moderate members really worry about what potential impacts are to the program that will affect their neighbors and their constituents. We've already seen in the Senate, through their budget reconciliation process, 2 members on the Republican side vote in support of a proposal which said there would be no tax breaks for billionaires if there were cuts to Medicaid benefits. That was Susan Collins and Josh Hawley. And then you've seen some of the House members that Liz talked about. So we go from this conceptual, hey, let's just move forward in the process argument that the speaker was using with his members yesterday to now what are the actual changes to taxes and benefits that are on the table. This chart walks through a number of policies that we understand to be currently in play based on our conversations with members and staff on the Senate Finance Committee and on the House Energy and Commerce Committee. Two caveats about this chart. One is these are estimates that are both from the Congressional Budget Office and the Center for Responsible Federal Budget. So there are always going to be refinements as policies are actually taken from concept and put into legislative language. The second caveat is to say these are all dialable. What year they go into effect, what are the actual cut points of different policies, but the goal here is to give you an order of magnitude of what these policies are, a kind of a sense of what they are, an order of magnitude on the scope of the potential impact. I think there's four ways to think about this year being very different than 2017, which are just important to keep in mind. One is the method. 2017, we saw congressional Republicans try a healthcare bill first, healthcare only. Here we're looking at either two bills or one bill, but either way it includes taxes with it. That presents both challenges and opportunities. Challenges for congressional Republicans from a messaging perspective about tax breaks for the wealthy and reductions to healthcare for low-income Americans, and a potential opportunity for something that is a priority on the Republican side to extend tax breaks. The speaker has been very clear with his members to say, you want to be on this train, not in front of it. And that is the strategy for the one bill. So 4 M's on why it is different than 2017. The method, second, the margin, 23 members that had the margin in the congressional Republicans in the House in 2017. Now we're looking at a margin of 1. Maybe that's 2 or 3 members by the time this all gets done. Third, there was a mandate that congressional Republicans understood themselves to have in 2017 when they pursued policies. That's different now. That mandate then to kind of repeal and replace the Affordable Care Act has, largely faded away. And then fourth, I think, is a mess. 2017, as Liz said, was super painful for congressional Republicans. And now they have to kind of look at this list or other lists similar to it to look at how to be able to make these trade-offs. What you see here is that on this list, you don't see block grants. Block grants were added in 2017 as a result of the political process, as political compromise. They were not included in the original committee passed product because of the challenges with that kind of policy approach. And the conceptual approach from congressional Republicans in 2017 was constrain spending without making any direct or many direct changes to actual benefits. It will be interesting to see if that's the approach taken here. What you see here are some fairly modest policies from a federal perspective. Keep in mind that Medicaid is about, I believe, is about $600 billion this year. And, we have a 10-year baseline, which would be roughly $6 trillion, maybe a little bit more, depending on kind of CBO assumptions. So it's a big baseline, and these are 10-year numbers. The first policy is to just pull out the American Rescue Plan Act, FMAP bump for new expansion states. One policy that will definitely be in anything that the Republicans do are work requirements, whether they're called community engagement requirements or not. If they're mandatory for states, they save about $140 billion. If they're optional for states, it saves probably about $30 billion. There's some choices there that members have to have about, is the policy driving or is the budget numbers driving? And I think what's been interesting is if you look at the early House Budget Committee proposal, in the actual legislative text of one of their early proposals, in their findings section, they noticed that work requirements pull 70 to 75% of approval for the American public. So I think a lot of members can, have this notion that people shouldn't get something for nothing. They should work for it if they can. But as we've seen, the actual cost, administrative complexity, and challenge for beneficiaries when these are rolled out can be very different than what members conceptualize. The couple of policies that the congressional Republicans are thinking about to reduce some of the ways that states inflate federal spending in their mind: provider taxes, reducing that safe harbor for provider revenue from 6% maybe down to 5% or 5.5%. Also thinking about constraining some of the growth in state-directed payments. One of the policies that will unite congressional Republicans is rolling back some of the Biden administration regulations. There, we look to the nursing staffing regulation that has significant new federal costs, the parts of the eligibility and enrollment regulation, which has new significant federal costs, and potentially parts of the access rule. So depending on if Congress blocks those because those have new federal costs that CBO projects to be in the baseline, there can be some scorable savings for that. And then we get into a bucket of policies that are really big, more structural policies that could have significant impacts that would impact states quite differently. One proposal is to reduce the FMAP floor. So statutorily, since the 1965, when the program was created, there's been this 50% floor, so that every dollar that goes out from the federal government is matched at 50% or more. The idea would be to reduce that maybe to 48%, 46%, 45%, which would impact states very differently depending on where they are in the distribution of FMAP. Second policy that has some appeal for members is to reduce the 90% match for the expansion population down to the normal FMAP over time. That was something that, when it was pursued in 2017, had very significant coverage loss for Americans to be uninsured. Whether or not most of those folks would flip into the exchange is something that remains to be seen, but could have very significant coverage shifts. And then a third policy is a per capita cap, a limit on the amount per capita, per type of enrollee, that the federal government will spend on Medicaid. So the idea is that Medicaid is an open-ended entitlement to the states and individuals. The federal government would cap that to say, we're only going to grow that by a certain percentage each year. You grow with enrollment, but it might not keep up with medical costs. So these are really big policies. These are the ones that now the committees working with leadership on both sides of the hill, both the House and the Senate, have to really begin to work through these trade-offs with their members. So expect a lot more engagement from members on these policies and a lot of iterating before we see what the next turn of events is. That's what's going on the congressional side. And I do want to turn, I think, Andrea, to talk a little bit about what's going on the administrative side from some of the executive orders and how that could impact Medicaid program policy. So if we go to the next slide, clearly we have seen we are just 5 weeks from Inauguration Day as of Monday. So, we are just 5 weeks in, and we've seen a flurry of activity from the administration. Executive orders and executive actions, even while they may not be focused on Medicaid, they can have a direct impact on program policy. So some of the changes to remove the federal focus on DEI certainly will have impacts for 1115 waivers for some of the policies that have been advanced there. Efforts that Medicare Advantage plans for DSNPs, dual special needs plans, caring for duals who are served both by Medicare and Medicaid. A number of those policies it will be impacted, and plans and states and providers will have to kind of shift strategies midstream. Second, I think we've seen a lot of activity and a lot of disruption from DOGE, a department that has been focused on reductions across the federal government. the so-called Department of Government Efficiency. There's reports out this morning that there may be looking at a new wave of broad federal layoffs, kind of remaking the final workforce. I think what we have seen for CMCS and even for CMS, both for Medicare and Medicaid at the federal level, relatively few disruptions relative to other agencies like USAID. But what we have seen is these personnel reductions are kind of asymmetrical and are having impacts as you pull program staff away. There are fewer people to approve and review content that needs to be moved forward. So we'll be watching very closely how that impacts like 1115 waiver applications, for example. I do think that over time you'll see three kind of dampening effects on some of the disruption from DOGE. One is cabinet officials we've already seen start to push back. Second is the courts as they're starting to look at this. And third is Congress. You're starting to see more members engage, some publicly and some behind the scenes on the Republican side, to express some concerns about the way that this is being done. Third, we've seen multiple actions and executive orders affecting immigration. There's a question about to what extent does it make certain individuals less likely to seek benefits. If there's questions around immigration status, how does it impact eligibility enrollment efforts? And then even for efforts to broaden and deepen the healthcare workforce, whether that's H-1B visas or others, there's questions about what the ultimate effect there will be over time. And then finally, more recently, we've seen an executive order to establish a commission for the Make Healthy America with a children's health assessment. Obviously, when you think about the confirmation hearings that Robert F. Kennedy Jr. had, he was kind of actively disinterested in the CMS portfolio, largely deferring that to Dr. Oz when he was asked about it. But between Medicare Marketplace and Medicaid, we're looking at something like 80-90 million Americans or more, and $1.6 trillion in annual spending. Throw in CHIP. I mean, these are very big platforms that could actually be used to drive policy forward, which I think Caprice will talk about in a moment. And all of this really highlights the role that individuals, whether they're in the White House or Office of Management and Budget or HHS or General Counsel's Office or CMS, the individuals in these roles will be enormously important.
So we can go to the next slide. Thanks, Josh. So again, as Josh mentioned, we have some early information about who the individuals are that are going to be executing on these executive orders and all the work that's going to be happening at HHS. We all saw Robert Kennedy be confirmed as the HHS secretary this month. A couple things to point out on this slide. One, you can see where we have noted with asterisks the individuals that will need to go through Senate confirmation. Those are highlighted in red in the bottom part of the org chart. You'll notice as you look through FDA, CDC, NIH, and CMS, all physicians, Dr. McCary, Dr. Weldon, Dr. Bhattacharya, and Dr. Oz, again, physicians. And then you have Tom Engel and Jim O'Neill. The thing to remember about those two individuals, they have been in the administration before, and non-physicians. You can see in the upper right-hand slide, the leaders that are yet to be announced, anywhere from Indian Health Services over to HRQ. So again, early days, quite a few people to go through confirmation and quite a few individuals yet to be named. Under Dr. Oz on the CMS part of the administration, we know that there are several, again, you've got a mix on the team of folks that have been previously at HHS under the prior Trump administration and some new folks. We know Stephanie Carlton will be the chief of staff. Understand that Drew Snyder will be leading CMCS as new staffs and new to HHS. And then you've got folks that are returning that were there in the prior administration, John Brooks as COO, Chris Klomp to lead Medicare, and Abe Sutton to lead CMMI. Still have not heard about two key positions under CMS. One is around program integrity, and one is around quality with the CCSQ. So next slide. So as Josh mentioned, on February 13th, we got some insight into an executive order about Make America Healthy Again, and really what the administration wants to push on. And we'll go to the next slide to go through some of the details of this. And really, this is focused on chronic conditions and really spells out in this executive order, again, that the prevalence of chronic conditions, not only in adults, but thinking through how childhood chronic conditions then obviously impact our health as adults, and really focusing on childhood chronic conditions. So again, this was signed on February 13th. The goal of this is to establish a commission. But again, thinking through childhood chronic conditions and the breadth of which that impacts. So the executive order mentions nutrition, exercise, it mentions environment, it mentions technology habits, food and drug safety. And one part that was mentioned, and you can see in the second row that we have there, is overutilization of medication. So there was discussion about drug safety, but also discussion about wanting to understand the prevalence and incidence of medications for children. As you go through this, we'll see that the commission is to be led by members from some of the key agencies: agriculture, housing and urban development, Veterans Administrations, EPA, OMB, the Council of Economic Advisors, CDC, NIH. So there are key members that have to be on this commission, and it will report up through the chairman that sits at HHS. And in terms of what will they do? So in the first 100 days, there's a clear assignment to do actually 10 different action steps, and we won't go through all 10 of those. But they really start out by looking at the data that exists, comparing the United States in terms of childhood chronic conditions to other countries, identifying the threats and the risks to children. Again, looking at the prevalence of drugs and how that's used to treat some of these. There is discussion quite a bit about transparency and about conflicts of interest, wanting to make sure that information that is yielded from federally funded studies and research, that there are no conflicts of interest with industry, and that that information is readily available. And really, the parts that you see, the two bullets in the green, evaluate the effectiveness of existing educational programs, again, around these big topical areas: nutrition, physical activity, and mental health, and then evaluate existing programs and funding intended to treat those. So that's what will happen. That's a tall order in the first 100 days. It's a lot of agencies and a lot of programs to look at. And we don't have clear guardrails around what does that mean in terms of effectiveness, and what will the evaluation entail. So that's the first 100 days. And then in the first 180 days, or the 80 days subsequent to that, the goal is to come up with a strategy. So again, the strategy that they're looking for says address appropriately the restructuring of the federal government's response to childhood chronic diseases. And this one, the quote was, ending federal practices that exacerbate the health crisis or unsuccessfully attempt to address it. And so again, the thoughts there would be around drug safety, food safety, and what the document describes as overutilization of medication, and also thinking about new solutions. So again, the goal is to bring together this commission that would be led by a chairperson at HHS. It represents all the departments that are impacted. Within that first 100 days, do the assessment, and in the next 80 days, create a strategy. So I'm going to now turn over, and this is great because this gives us a first glance of one of the things that the Trump administration is going to be moving forward. So we're going to turn it over to Beth to talk about other levers and actions that we think might happen.
Yeah, thanks, Caprice. And I did want to just comment on the Make America Healthy Again, that even though Medicaid is not explicitly named in that, or even CMCS having an official seat on that board that is going to be making the recommendations, it's highly likely that any kind of recommendations or strategies that come out of that would impact Medicaid and CHIP, because over 35% of children in the country are insured by Medicaid or CHIP. So we do expect that there will be some impact from that on the Medicaid and CHIP programs. So beyond Make America Healthy Again and the reconciliation process, there are more in the weeds kinds of policies that we think will start to get looked at. And I'll highlight a couple of those things. I will say though, it's very early and it's very hard to know what the shape of these might look like, how far they might go, whether they'll get picked up at all. And so we're really not able to speculate on that. This is really to raise awareness of the types of things that the administration has as levers to enact their policy priorities. So starting with program oversight, Josh has already touched on state-directed payments, which are additional payments that can be made through managed care plans to target specific types of groups or specific types of providers often to achieve quality objectives or specific outcomes. These have grown very rapidly in recent years. And as far back as 2006, the General Accounting Office and the Health and Human Services Office of Inspector General have been issuing reports that there needs to be more oversight, more controls on these programs. You may recall in the first Trump administration, there was the Medicaid Financial Accountability Rule, or MFAR, that was proposed that had far-reaching impacts to directed payments and often funded by the state share is often funded by provider taxes. So there's a tie in there. However, that rule was withdrawn. And so I do think, though, that there may be another attempt to do some kind of oversight or put some more parameters, even roll back the Biden administration expansion of these types of payments. So there will likely be scrutiny. It is has crossed different administrations of different parties. Also, on improper payments, I would just say that's a perennial issue in healthcare. It pretty much always gets brought up when you're looking for ways to save money, is to look for fraud, waste, and abuse in the system. So I'm sure there will be some look at that. In terms of revisiting regulations and guidance, one of the executive orders that's been put out states that for every new regulation or rule or guidance that the administration wants to put out, they have to revoke or repeal 10 regulations, rules, or guidance. So that will mean that if they want to advance their own priorities, they'll be needing to look for things to roll back or remove. These could be old, obsolete types of things, or they could be things from the prior administration, and so on. So Josh already went into some detail on some of those that might be targets. I'll briefly mention some of those. There was a large eligibility and enrollment rule that was focused on making it easier for people to enroll and easier to stay enrolled or to re-enroll. There was a large managed care rule that had access requirements, quality requirements in it. The nursing home staffing requirements, which came with a large price tag as well. There's the mental health and addiction parity guidance and a number of large reporting requirements. So these are all potential targets for full or partial rollback. I'll talk a little bit more about Section 1115 demonstration initiatives in a minute, but I would say that this is a really important area, because this is the area of almost the greatest flexibility in Medicaid, where there's a lot of discretion that the Secretary of HHS has to approve new types of policies, somewhat experiment, demonstrate new things. And so it is an area that's ripe for an administration to put their own stamp on programs. So you may have them relooking at the justice involved initiatives, although there was interest in that in the first Trump administration. There was a big emphasis in the Biden administration on health-related social needs, and there were lots of waivers demonstrations that were approved that expanded Medicaid payment for health-related social needs. Now, there may be a connection here to Make America Healthy Again and looking at whether preventing chronic conditions is connected to health-related social needs. If that connection is made, then there may be support for continuing those policies. We touched on work requirements, certainly something that was promoted in the first Trump administration. There were a lot of demonstrations that were promoted and approved that were related to work or community engagement requirements. And there may be new opportunities depending on what's coming out of as policies start to firm up. There will be likely guidelines for what types of demonstrations would get approved in the new administration. And then there are just a couple other types of activities. Value-based payments. There are lots of programs and models out there now. Will these be reevaluated? Will there be new models put forward to promote other policy goals or to try to find savings? These are, that's an area that is ripe for being looked at. Rural healthcare could be looked at, behavioral health, and then as Caprice already mentioned, a lot of focus on chronic disease and children's health. And we may see new types of models coming out on those. Next. Going to dig in just a little bit more here on the Medicaid 1115 demonstration programs. I think most of the people on this webinar probably know that this is a type of authority that allows for new types of programs and different types of flexibilities within Medicaid that they're often not able to be done any other way. And so we bucketed these into 3 different ways to look at the demonstrations. You've got those that are already approved, but may need to be amended or renewed during this administration. You have those that are still pending that did not get approved during the last administration or that have been submitted since then. And then you have future ones that may get put forward. So I'll touch briefly on each of these. So those that are already approved, they will likely, most likely to be have some kind of action on them when a state is submitting them for an amendment or a renewal. And at that time, even if, for example, an amendment that's pretty narrowly tailored, CMS could open it up and look more broadly at provisions that were previously approved. And will be reviewed very carefully. So they can and likely will go beyond what the specific areas that are being targeted by the state. With the pending ones, there was a flurry of activity in the last months of the Biden administration to approve quite a number of demonstrations. There were many that were approved in December, but there are still some that are outstanding, and there may be others that have come in since then. So they may undergo a negotiation process that starts to see the beginnings of the new administration's priorities. I would say these first 2 buckets, there will likely be a slowdown in work on them. There is not a time frame for approval of 1115s, and so they're not on any kind of clock to approve these. And there will likely be some need for the people who work on them to get the guidelines and the parameters of the new administration. So we'll probably take a little while to get those through. And then finally, for the future, what we've seen in past administrations is that they may put out some kind of policy guidance or some kind of a bulletin that would encourage certain types of demonstrations to be put forward and say, if you submit a demonstration of this type, it is likely to be approved if it's within these parameters. So I think that that's something that we'll see in the future as the administration's policy priorities around Medicaid start to solidify, might come out of the Make America Healthy Again executive order or any other kind of policy decisions. We do know that there may be some areas of special interest already emerging, such as the focus on chronic disease prevention, not just management of it, but getting upstream from that. Next. All right. So the final part of this presentation is really to think about what you can be doing now. It's a lot of challenges with a lot of moving parts right now. And I've heard from a lot of organizations that feel a little bit paralyzed and not knowing what they can be doing. So we expect that we'll continue to see a lot of change and over the next couple of months as we start to see what policies gain traction. But what you can be doing now is you can be looking at we put it here as SWOT, but strengths, weaknesses, opportunities, and threats, and analyzing that for your programs and your organization's priorities, and say, to try to play out some of the scenarios that could happen here and the options, and prioritizing which ones are most important to you, which ones maybe are at most risk of a change that would be difficult for your organization. You can look at the data that's available to you to assess those, to look at where areas where you're ready to maybe be flexible or maybe not be flexible. How ready are you to make those changes? And also conducting financial impact analysis. And kind of having that information in hand will make it easier for you to assess the new proposals as they come out or new iterations of proposals. And then you can start to identify allies and alliances around the goals that you have and the priorities that you have to develop a federal strategy and to shaping that federal policy. There's a long way to go. Hopefully you've gotten that out of this webinar. There's a lot of steps left before we start to see concrete policies that will impact programs. And there's opportunities to shape that as you go if you have good specific information about the changes and how they would impact you and what you might like instead or as a compromise. And then also there may be a need to develop strategies within your own state to adapt to the risks. So states may have to make some changes in their policies or their financing to accommodate the changes at the federal level. And then finally, it's really important that you establish mechanisms to stay connected and to stay grounded in what's happening. As these things move through the process, it will not stay static. And it'll be a while probably before things settle into more of a steady state. So it'll be important for you to get used to kind of keeping up with the developments that are happening. And so you can adjust your analysis of impact and risks. All right, so hopefully that gives you an idea of things you can be doing, and I'll turn it back over to Andrea.
Great. So I'll invite my colleagues to come back on screen, and thank you all for really these important insights at this point in time, and also the questions that we're getting in the Q&A box. A wide variety of questions, but one that I want to start with is just a clarification. Josh, on the chart that you shared with the list of proposals, we had a couple people asking about just confirming that those are 10-year numbers, right? And those came from the source again. Can you just repeat that?
Yeah, it's a combination of the Congressional Budget Office and the Center for a Responsible Federal Budget. Center for a Responsible Federal Budget is an independent nonprofit organization that looks at budgetary issues across the federal government, across programs, and it's a mix of them linking to CBO scores and also their own analysis from their experts.
And can you, some of the regs that are mentioned, the staffing, the nursing home staffing standards, and the access reg, could you or Caprice and Beth speak to some of the potential provisions that might be of interest either through the legislative process or that the new administration officials might be taking another look at?
Maybe I'll start and invite my colleagues to jump in. So the nursing staffing reg, in total, there was some bipartisan concern about the scope of the mandates that puts on providers and whether or not the workforce is actually there within the United States to be able to discharge what was the requirements that were put in place. The reg did have a lot of exceptions, but a lot of the uncertainty and concern from providers was we don't know if we'll get an exception. And so we would like to have quality, we would like to have a good workforce, but because of some of the workforce challenges, it's not always possible to hire those jobs where they are across the country. So I think that in total is probably likely to be scrapped. I think around the access reg or the eligibility enrollment reg, it would be more targeted to pieces of those regulations that, from a congressional Republican perspective, add costs without adding much value, and are, more kind of inflationary for the growth of the Medicaid program and kind of federal spending.
Yeah, I think that's right, Josh. I know in North Dakota, we took a look at that and we didn't have nursing homes that thought they would be able to meet any of it. I think thinking about the exceptions of we're a very rural state, but most states have rural areas, right? And then the other thing about that staffing rule is it really focuses on CNAs and RNs. It really left out LPNs. And so then there was a question about where do those folks go? Do they all shift over to the hospital side? And so it wasn't just that we don't have the workforce for that, but it also is like big major shifts in the workforce and how quickly we could accommodate to that. And again, we have staffing ratios that we set internally at the state. And we do monitor that in terms of how our quality. I don't know, Beth, if you had other thoughts on that or if we want to move on.
Just briefly, I mean, it's highly speculative at this point what things would go forward, but there are new requirements. So, for example, in the managed care rule for certain appointment wait times and requirements for states to do secret shopper or to ensure that there are secret shopper requirements. These all come with a cost. They do cost to implement some of these policies. There's reporting requirements. So again, if they're looking to find some small places to save money or to reduce mandates, then these are all things that they could revisit.
Thanks. Just picking up on that point of it is pretty speculative what may or may not happen, but the Medicaid access rule, anything you would call out in that rule as that might be getting more scrutiny over the next couple of months?
Nothing that I would specifically identify right now, as much as I think because the environment is kind of dialing for dollars, I think all the major regs that have spending provisions in them will be examined.
Thanks. Lots of questions, unsurprisingly, about the work requirements and the potential for that either legislatively or potentially through the 1115 demonstration process. Josh, you mentioned that you thought it would absolutely happen. Can you say, are you anticipating that as a mandatory policy? Should we be thinking about it as an option, just kind of paving the way for states that are interested? Or how should folks be thinking about that right now?
Yeah, it's a good question, and I don't think we know the answer to that yet. I think I've just been struck by in conversations with folks on Capitol Hill on the Republican side that to them, obviously nothing about the future is certain, but to them it's just kind of in the baseline. People are like, of course we're doing that. So I think if you're trying to get to a bigger budget number, it probably pushes more towards mandatory. That's $100 billion difference if you're trying to get to that 880 number, and maybe preferable compared to some other policies. But I think the other question is 880 the final number? And we don't know the answer to that. To actually look at how things could be amended as the process goes along. So, or other policies that could come in. So I think that is just a live issue that people are still working through.
And then for Caprice and Beth, from your perspective, I know I'm seeing as I'm looking at state budget proposals and governors releasing their proposals, a lot of, and this speaks to some questions about what are states doing right now. Many of them putting in a marker for their, signaling their interest in these types of requirements. How would you advise states to be thinking about the proposals that are, whether it's legislative or maybe new opportunity through 1115 authority?
I'll just say quickly that CMS does have a process once they get the new team in place to work with states on concepts, really to start out at that highest level of what are we trying to accomplish, what is the best vehicle to do that, and how do we move forward. I also think that, to Josh's point, if we see work requirements being pushed out on a larger scale, whether it's mandatory or whether more states take them up, I could see how the administration might think about, is there a more standardized way to do this through preprints or through, an easier way to get this started, and even thinking about providing funding for some of that complex administrative infrastructure that's going to be required. We've seen that in some of the other 1115s. So I think as we see state legislatures start to have these conversations and really think about the timelines that it would be required, the money that's required on the front end, and really encouraging that if your legislature is going down that road, to get in touch early, and often when that state demonstrations group is set at CMCS, to start to work through how would you do that in the most cost-effective way. Beth?
Yeah, I think sort of taking it, I totally agree with all that. I would also say that, so for some state Medicaid programs, they need to get authority from their state legislature to make significant changes to their program. Depending on it, some have to have authority to seek a waiver or a demonstration. And so if states are thinking right now that they might want to take advantage of some of the new policy initiatives that will come out of the administration, they may want to, we may see some states going ahead and putting it in, say, if allowable, but at the federal level, you can seek this type of authority. So some states may state legislatures may get proactive and start to put potential programs into it pending federal authority. So you may start to see that. It's really early for that right now, but a lot of legislatures are starting to go into session now. So we may start to see that type. Others may say, wait and see, let's see what is allowable before we pass that.
I think we have time for 2 more questions. I want to touch on states that have recently approved 1115 demonstrations. And Beth and Caprice, you guys have sat in different seats and engaged with, when you were serving as Medicaid directors, with peers across the country. And what advice do you have for Medicaid stakeholders who are, looking at what the administration is potentially scrutinizing and the future pathway for 1115s? What advice do you have for them, or what should they be considering? Should they be nervous about changes to 1115s that have been approved, or any recommendations for them?
Yeah, I think it's just like we said kind of at the end of the presentation, which is it's a good time to be doing a risk analysis and to be looking at those policies that you have in place or authorities that you have in place, and which ones might be something that would be scrutinized given the conversation that's going on, and just start to think about, are there alternative ways that you could do this? Are there other authorities you could use? And to start to marshal, for example, if you've seen impact from those programs, to be able to put your evidence together, so that if you do need to justify it, or that you get in a conversation with CMS about whether that authority would continue, that you would be able to marshal your allies and your evidence to say that these programs should continue. So I would never say it's never black and white. With 1115s, it's a lot of negotiation. So go ahead and start to put your negotiation points together.
And just really quickly, engage. We're required to do public comment periods. We're required to put things out to talk about at your MMAC meetings. Please engage. If there's work groups and task forces pulled together, we listen to your comments, we read those things, and we take them very seriously. And if something also you see is, there might be some abrasion there, propose a solution. Because sometimes we don't know what's happening on your side, on the field side, on the operational side. And so the more solutions you can bring to the table, the better.
Great, thank you. And I think, Caprice, we're seeing you put on your Medicaid director hat right there, and giving people advice on that perspective. So that's great. I want to close out by just turning to you, Liz, and the timelines. There's so much attention on like when are things going to happen. Can you just give us a really quick and dirty summary of like what's next, what's going to happen in March, kind of general timeline so people have a sense of what to expect?
So I would expect that we have, I'm going to call it a final budget. So an agreement between the House and Senate. I don't know, maybe the next 2 to 3 weeks. It really depends on how quickly they can come together. And in that budget, it's going to tell us how long the committees have to kind of do their homework. So we'll know which committees are going to be involved, how much money they have to save. So that's going to give us some indication. So probably within the next 2 to 3 weeks. And then it really is going to depend how long they give the committees. I'd say it'd probably be within the next month or so to have the committees come up with their packages of policy options.
Great, thank you. Colleagues, any final words? Josh, I'll start with you.
We're here to help, and let us know. We know it's an uncertain time, and if there's any ways we can be an assistance to your organization as an enterprise, please reach out.
Great. Thank you. We do have, if you want to get into the nuts and bolts of reconciliation, we have a webinar on demand with Liz. You can hear more from her about that, as well as several other webinars on the election impacts to ACA marketplaces and Medicare Advantage. Clearly there's a lot going on, and we'll probably be back in your webinar feed again sometime soon with a discussion on how things have evolved after today. So thank you very much for joining us.